All right, so we'll start our discussion with lung cancer staging. And the importance of staging is that it gives us an idea of the prognosis, but it also allows the clinicians to place the patients in various treatment protocols. So it's the staging that determines what treatment protocols are offered to the patients. If you compare clinical staging to pathologic staging, so with clinical staging, we're basing the staging on what we see as far as imaging goes and physical exam, et cetera, whereas pathologic staging is actual biopsy of lymph nodes. And what we find is that the survival is better for pathologic staging. And what would be the reason for that? No, it's just lead time bias, because with pathologic staging, you're actually sampling the nodes. So if there's microscopic tumor within the nodes, that's going to be picked up on pathologic staging. So that kind of gives you a lead time bias and upstages the patient. And in that upstaging, when they're upstaged, you're catching them at a very early stage in that disease. So at that particular stage, there's a lead time bias. That's the only reason. So just realize that. When it comes to the TNM descriptors, I've given you this in the handout. This becomes very complicated. So, when you're sitting there and actually reading a case, trying to stage a patient, et cetera, you always need the cheat sheet next to you. But there are certain things to remember that might come up on exam questions. So that's what I'm going to talk about now. So the numbers to remember are 3, 5, and 7. So let's remember the numbers 3, 5, and 7 when we're dealing with the T staging. So T1 is less than or equal to 3 to 5 centimeters, 3 centimeters. T2 is between 3 and 5 centimeters. T3 is between 5 and 7. T4 greater than 7. The other difference is the difference between a T3 and a T4 tumor has to do with structures that are invaded. So if there is invasion of resectable structures, so the chest wall, the parietal pleura, the parietal pericardium, all of those are considered resectable structures. So that would make it a T3 tumor. That's still an operable candidate. A tumor is T4 if it invades structures that are unresectable. So here, think of the midline. If it invades, regardless of the size of the tumor, if it invades the mediastinal fat, if it involves the diaphragm, the myocardium, great vessels, trachea, esophagus, vertebral body, carina, any of that would make it an unresectable tumor. That makes it a T4 tumor. If you have separate tumor nodules in the same lobe as the primary tumor, so if you have a right upper lobe tumor, again, regardless of the size, with tumor nodules surrounding it in the right upper lobe, that's a T3. But if we have separate tumor nodules in a different ipsilateral lobe, so if you have a left upper lobe tumor and you have a tumor nodule in the left lower lobe, that makes it T4. If the tumor nodule is on the other side, though, that makes it metastatic disease. Now, the N descriptors, this is also something that you should remember, and this is also fairly easy. So N1 is ipsilateral up to the hilum. N2 is ipsilateral up to the mediastinum. Subcarinal nodes count as ipsilateral nodes, so that's N2 disease. N3 is whenever you have contralateral lymphadenopathy or supraclavicular lymphadenopathy. So contralateral, hilar, or mediastinal nodes, or if you have supraclavicular nodes, that makes it N3. There's an important distinction between N2 and N3. Up to N2, the patient is still considered a surgical candidate. Once you get to N3, then surgery is no longer an option for the patient. So you need to distinguish between N2 and N3 disease. For metastatic disease, M1A is if we have mets confined to the thorax. M1B is if you have a single extrathoracic metastatic lesion, and M1C is if you have more than one extrathoracic metastatic lesion. So the M descriptors are also fairly simple. So malignant pleural effusion is also considered metastatic disease. So here we have a PET scan. You can see the activity in the tumor, and you can see the activity there within the pleural metastases. So this would be considered M1A. So malignant effusion is is metastatic disease. And then for the staging, you can put the T staging and the N staging together, and you look at a chart, and that gives you the staging for that particular patient. And again, the staging determines the therapies that would be offered the patient. Up to stage 3A, the patient can still be considered a surgical candidate. Once you get to stage 3B, then surgery is usually not an option for those patients. Okay. So if we have a 5.2 centimeter tumor here, no lymphadenopathy, no metastatic disease, and we have to sit here and stage it, well, 5 centimeters makes it T3, and if it's M0, M0, so it's stage 2B, right? So T3, M0, M0, stage 2B. So this is pretty easy to do as long as you're using the chart there. Here we have a 4.3 centimeter tumor, and we're trying to figure out the stage. But aside from the size of the tumor, there is something else you need to notice, and what is that? There's what? Well, it's not metastatic disease, although, in essence, it is extension of the tumor. There are satellite nodules, right? So these satellite nodules are in the actual tumor lobe, right? So satellite nodules within the actual tumor lobe, again, regardless of the size of the tumor, makes it a T3 lesion, okay? So you have T3, N0, M0, and again, that would be stage 2B, all right? Here we have a left upper lobe tumor. There's a nodule here in the left lower lobe, okay? So that nodule is outside of the ipsilateral, of the primary tumor lobe, but it is still on the same side. So is that T3 or T4? That's T4, right? That makes it T4. But you also notice there's another finding here on the soft tissue windows. What's the other finding? Besides the tumor, there's another finding here. Not hilar, that's the tumor itself, but there are lymph nodes where precarinal lymph nodes, right? So that would be mediastinal nodes, so that's N2 disease, okay? So you have T4, N2, M0, that makes this a stage 3B, so this patient would not be offered surgery given the staging of this tumor, okay? So here's a tumor here. If I tell you that there is no lymphadenopathy, there is no metastatic disease, there is something you need to notice about what this tumor is doing, and what do we notice? It's invading the chest wall, right? This tumor is invading the chest wall. Is this tumor resectable? Yes or no? I told you that the tumor is right here. Here are the vessels. Is this tumor resectable? No. It is. Remember, the chest wall is resectable, right? So involvement of the chest wall is T3 disease. T3, N0, M0, stage 2B, resectable, okay? So the chest wall, the parietal pleura, those are all considered resectable structures, okay? Signs of unresectable tumors, signs of a T4 tumor. Think of the structures in the midline. If the tumor involves the trachea or the carina, if the tumor involves the great vessels, or if the tumor extends into the mediastinum, involvement of the vertebral body also would make the tumor a T4 tumor. And then pleural metastases, of course, is M1A. That's not really T4, but that is M1A. So this tumor here, what's this tumor doing?
It's invading the vertebral body.
Yeah, it's invading the vertebral body. So what T stage is that? T4, right. So this is T4 N0, M0. Now, having said that, there are certain centers that do attempt surgery on these types of tumors. T4, N0, M0 turns out to be stage 3A. So at specialized centers, they can try to resect this tumor, do a resection, and you can see it involves a major type of reconstructive surgery to reconstruct the vertebral body, right? And it turns out that the prognosis when you're dealing with these T4 lesions have to do with the extent of lymphadenopathy, right? So if you have no lymphadenopathy, N0 disease, the 5-year survival is 62%. Even if you have N1 disease, the 5-year survival is 51% in these T4 tumors. But once you get to N2, the 5-year survival really drops. So maybe at that point, you would not offer surgery to these patients. So the staging is very important in terms of what therapeutic options you can make available to the patient. This tumor, there it is this resectable?
No,
Why not?
it's invading the pulmonary artery.
Right, this tumor is involving the pulmonary artery here in the mediastinum. It's involving the main pulmonary artery right there. So that would be unresectable, okay? Now here's a tumor here in the left upper lobe causing left upper lobe collapse. Then we have these mediastinal lymph nodes we can see that are enlarged because of this. And how confident can we be on CT that these lymph nodes contain tumor? What is the positive predictive value of CT? How good is CT for assessing lymph node involvement with tumor? Is it good or not good? What do you think? It's what? How bad is it in terms, would you believe that the positive predictive value is about 50%? It's about as good as flipping a coin. So CT is notoriously poor for evaluating lymph nodes to decide if the lymph nodes contain tumor or not. Hence, the preferred test is what we do for staging lung cancer is PET, right? That's why we go to PET. So on CT, all we have to judge the involvement of lymph nodes is the size of the nodes. So if you have, we usually use 1 centimeter for the mediastinum. So we tend to use that as the cutoff for involvement of mediastinal nodes. But there are other causes of lymph node enlargement. You can have reactive hyperplasia to post-obstructive pneumonia, to atelectasis. You can have prior diseases like TB and sarcoid that can also cause lymph node enlargement. So in this study that was done quite a while ago where they had pathologic correlation with the CT scans, so they looked at, here lymph nodes between 2 and 4 centimeters. Those are pretty big nodes. 37% of those nodes in patients with lung cancer were free of tumor, okay? So you can have normal sized lymph nodes on CT with microscopic foci of tumor. So the lymph nodes might look perfectly normal, but they can still have tumor within the nodes. So it turns out that the performance of CT, the positive predictive value, is about 56%. It's not really very good. So CT is not very good for assessing lymph node involvement because all we have to go by is the size. Turned out these nodes were actually negative for tumor. That was just reactive because of the post-obstructive pneumonia in this patient. So hence we use PET. And with PET, what you can do is not only evaluate the tumor itself to see if it's active, if it fulfills you, if it makes you more suspicious that this is a neoplasm, but also you can evaluate the nodes. So here you have activity within the nodes, plus we scan the whole patient, the whole body. So you can also evaluate for metastatic disease. Here you can see activity within the spine and within the sternum. So you can really have staged the patient with PET-CT. So here's an example where the staging does become really important in terms of what therapies you're going to offer the patient. There's a tumor here in the right upper lobe, but here we have lymph nodes on the other side, and on the PET-CT we have active lymph nodes here, contralateral active nodes, makes it N3. So that means that surgery is not an option for this patient. Okay. So sensitivity and specificity for evaluating mediastinal nodes. If PET-CT is positive for distant disease, remember that if we have that, if we upstage the patient, then we can no longer offer surgery as an option. And surgery really is considered the only really curative option that is available for lung cancer. So if you're going to deny the patient surgery, you do want to confirm that there is distant disease, that there is metastases, or that the lymph nodes are really involved with tumor before you deny surgery to that patient. So positive mediastinal nodes usually require histopathologic confirmation if that means that we're not going to offer surgery anymore to that patient. Now talking about lymph nodes, There are terms that we use in CT and also in PET when we're evaluating lymph nodes. And there's a formal nomenclature for the lymph nodes where they are assigned numbers depending on their location. I don't expect you to memorize the numbers, but I do expect you to know what the locations of these lymph nodes are, because this is what you're going to be putting in your report when you're describing lymph nodes. So you have to be familiar with what these terms mean and where these nodes are located on a CT scan. So if we're talking about supraclavicular nodes, we're talking about nodes above the first rib. So nodes at the thoracic inlet above the first rib, those are supraclavicular nodes. If we're talking about paratracheal nodes, you can have upper paratracheal nodes and lower paratracheal nodes, but now we're inside the thorax and we're talking about, we're in the thoracic cage, we're talking about alongside the trachea itself. So you can have right paratracheal nodes, you can have left paratracheal nodes, all right? So those are paratracheal nodes. Precarinal nodes, so if we say that, we're talking about lymph nodes here, anterior to the carinum. And then subcarinal nodes, we're talking about lymph nodes right underneath the carina, over here, right? So these would be subcarinal lymph nodes, if we find lymph nodes down there. Prevascular nodes, these are nodes in the anterior mediastinum. So if we say there's prevascular lymphadenopathy, we're talking about lymph nodes over here, okay? Para-aortic, subaortic, which is the same as aortopulmonary window lymph nodes, so we use that term a lot, aortopulmonary window lymph nodes. So para-aortic lymph nodes, that's lateral to the ascending aorta. So those would be nodes over here. Aortopulmonary window lymph nodes, so these are nodes lateral to the ligamentum arteriosum. So the ligamentum arteriosum is in this region here, over here, okay? So lateral to that, over here, is where we would find the aortopulmonary window lymph nodes. So those nodes, the line of the ligamentum arteriosum would be around this region, okay, connecting the aorta to the pulmonary artery. So lateral to that is the region of the aortopulmonary window lymph nodes. So here are some examples of these lymph nodes. So para-aortic nodes, number 6, kind of adjacent to the ascending aorta. Subaortic or aortopulmonary window lymph nodes, those are these lymph nodes out here. And then lymph nodes in here, these are not AP window nodes, these are considered left paratracheal nodes. So medial to the ligamentum arteriosum, those are considered left paratracheal lymph nodes. Another example here, we can actually see the ligamentum arteriosum right here. Okay, so you can see the pulmonary artery here, and you can see the aorta here. Okay, and so here is the para-aortic node, and then here would be the aortopulmonary window lymph node. So there's the AP window lymph node right there, lateral to the ligamentum arteriosum. Another very nice example where we actually see the ligamentum arteriosum here calcified. So your left paratracheal nodes are medial to the ligamentum arteriosum. The aortopulmonary window lymph nodes are lateral to the ligamentum arteriosum. So use these terms accurately when you're describing lymph nodes on your CT scans. Now, hilar nodes, technically these are nodes adjacent to the main stem bronchi, all right? But if we get below the level of the main stem bronchi, then technically these are called interlobar nodes in this region, although, you know, really in CT, we tend to call all these guys hilar nodes, even down here, okay? I guess that's okay. But there is a difference between hilar nodes and interlobar nodes. Paraesophageal nodes, next to the esophagus. So here's the esophagus, nodes down here next to the esophagus. Those are paraesophageal nodes. Some other terms, internal mammary nodes. So these are nodes adjacent to the internal mammary artery. So you'd find those parallel to kind of alongside the sternum, along the inside of the chest wall, right next to the internal mammary artery and vein. Those are internal mammary artery nodes. And then cardiophrenic angle lymph nodes, they can be on the right or the left. So your cardiophrenic angle is over here where you have the heart and you have that fat, and the cardiophrenic angle is right next to the heart. So you can have cardiophrenic angle lymph nodes too, either on the right or the left. So for patients with non-small cell lung cancer, they'll have chest X-ray CT, PET CT, if we're thinking about staging the patient, and if we're going to, especially if we're thinking about doing surgery, because we want a direct lymph node sampling to the lymph nodes that are active to be able to accurately stage the patient. Biopsy mediastinal nodes for stage 2 tumors before surgery, because you want to accurately stage the patient. PET CT, if PET CT is negative for lymph nodes, but if the tumor is small, less than 1 centimeter, or if it's a ground glass attenuation lesion, has ground glass attenuation associated with it less than 3 centimeters, here the reliability of PET is pretty good, so biopsy of mediastinal lymph nodes for these small early tumors is optional. Okay.
Dr. Mountain?
Yeah.
If the PET is negative and the nodule is greater than 3 centimeters ground glass or solid, would we still biopsy the mediastinal?
At that point, the patient would go to surgery,
Okay.
and then what they would do is, when they're operating, they would sample the nodes anyway.
Okay.
26-year-old man with a lung mass. So this is a young patient with a big lung mass here. Of course, bronchogenic cancer always in your differential, but the patient is rather young for bronchogenic cancer. And then on the CT, it has this peculiar appearance. So here's non-contrast, here's post-contrast. We can see that there's calcification associated with the tumor, and we can also see that there is enhancement here associated with the lesion. So any thoughts as to what this might represent? What? Hamartoma? Teratoma? Well, teratomas occur in the mediastinum, not in the lung parenchyma. Okay? Yeah, carcinoid tumor, especially in a younger patient, especially in a tumor that's calcified. So that is another class of malignant lung neoplasms in addition to bronchogenic cancer. So another appearance that we might see is an appearance like this. So if you have a branching tubular structure like this, there's a particular sign that we call this. What is the sign? What? No, this is not a Loof-Sickle sign. A Loof-Sickle sign is not a branching tubular opacity. What is the Loof-Sickle sign?
It's like the opposite of the golden S sign on the left side.
Yeah, so a Loof-Sickle sign is when you have hyperlucency adjacent to the aortic knob. The Loof-Sickle sign is associated with left upper lobe atelectasis. The branching tubular opacity like this, what sign is this? This is the finger and glove sign. So the finger and glove sign indicates what?
Could be like allergic.
Well, never mind the disorder, but what is the sign indicating? What gives you the finger? Mucus plugging. So the finger and glove sign is a sign of mucoid impaction, right? Yeah, you can see it with ABPA. You can see it with the congenital bronchial atresia. You can also see it with a slow-growing endobronchial neoplasm like carcinoid. So carcinoid, because it's a slow-growing endobronchial tumor sometimes, can present as mucoid impaction. Here's the finger and glove sign. And in this particular patient, you can see that there's low attenuation here, which represents the mucus, but there's an enhancing endobronchial lesion here. Here's the branching opacity from the finger and glove sign. This was a carcinoid tumor. So carcinoids are vascular and they can present as endobronchial tumors. A year later, the tumor got even larger. There you can see the enhancing component of this tumor that actually presented with mucoid impaction on the chest radiograph. Okay. So carcinoid can also present as an endobronchial lesion, so it belongs on our differential diagnosis for endobronchial lesions. So these arise from neuroendocrine cells that can produce serotonin, ACTH, bradykinin, and they're divided into 3 types, typical, atypical, and the more at the very severe spectrum you run into small cell lung cancers. So most arise endobronchially if you're talking about typical carcinoid tumors, although not all of these are benign. About 15% can have metastatic disease, and the bulk of the tumor can be outside of the airway, so that can give you what's called the iceberg sign, where on bronchoscopy they'll see the small component inside the airway, but much of the rest of the tumor might be outside of the airway. So here's another example. There's a lesion here that is enhancing endobronchial lesion associated with left upper lobe collapse. Here you have that's a loose sickle sign, right. So here there's this lucency adjacent to the aortic knob. That's the loose sickle sign in this patient with left upper lobe atelectasis. The atypical carcinoid is somewhat more malignant, metastatic disease up to 50% of cases. So here you have lymphadenopathy associated with this atypical carcinoid tumor. And then this was a woman who had no smoking history. So she presented with this lung lesion here that turned out to be a carcinoid tumor. So this is another class of lung neoplasms that you can consider, especially in younger patients and patients also who have no smoking history. This appearance has also been described with carcinoid tumors where you have a central lesion near a bronchus with an eccentric calcification. So calcification, especially eccentric calcification, can also be associated with carcinoid tumors. All right, so that's another appearance that we need to be familiar with. How is lung carcinoid staged? Well, the good news is it's staged just like bronchopulmonary cancer, bronchogenic cancers, no difference. So everything that we discussed for staging of bronchogenic cancers is going to be the same for the staging of carcinoid tumors. So we come across this interesting case. This is a 44-year-old woman with shortness of breath, and on the CT there is air trapping, and there are also these additional small nodules, right, in this patient. So keeping in mind the theme of our conference, anything we have to offer as to what this might represent. Well, it could be metastatic disease, but metastatic disease is not associated with air trapping. How do we put the air trapping together with this finding? And at this point, it's very easy for me to tell who actually looked through the material that I've given you and how many of you didn't, right? So the answer is it's a very rare disease. This is called diffuse idiopathic neuroendocrine cell hyperplasia, abbreviated as DIPNEC. So here what we have is neuroendocrine cell hyperplasia within the peripheral airways, can also be associated with carcinoid tumorlets. It's considered pre-invasive, tends to affect middle-aged to older women, and it results in air trapping because it's around the airways and can result in constrictive bronchiolitis. So these patients can have nodules, air trapping, and bronchial wall thickening. So neuroendocrine cell hyperplasia, the basement membrane is not involved. With carcinoid tumorlets, there's a little bit of involvement of the basement membrane. With carcinoid tumor, what differentiates this from carcinoid tumor is there is more invasion of the basement membrane. So diffuse idiopathic neuroendocrine cell hyperplasia, or DIPNEC, can give you multiple nodules and air trapping. All right. So here we can talk about then neuroendocrine malignancies as they involve the lung. At the pre-invasive stage, we have DIPNEC, low-grade typical carcinoid, intermediate atypical carcinoid, high-grade large cell cancer, and then the highest grade is small cell lung cancer. All right, so the finding on this chest radiograph is was that normal or abnormal? Well, okay, so what's abnormal? What would you describe as abnormal here? Yeah, so there are reticular opacities predominantly on the right side. What do you call these lines? Yeah, this patient has curly B lines. So you have interstitial opacities, but they're only on one side. All right, so what could this be? Yeah, so that of course is the topic that we're going to be discussing. Could it be unilateral pulmonary edema? Certainly, unilateral pulmonary edema can give you edema like that or an appearance like that on one side, and we'll talk about in more detail in the future the differential for unilateral pulmonary. Give me the most common cause that we might see unilateral pulmonary edema in this hospital. No, but well, how do re-expansion, right? Re-expansion pulmonary edema, right? Associated with a large pleural effusion or pneumothorax, right? So re-expansion pulmonary edema is certainly something you should think about if you have what looks like, unilateral pulmonary edema. But this was lymphangitic carcinomatosis. So you gave us the answer. Tell us what diseases are associated with unilateral or so asymmetric lymphangitic carcinomatosis. Well, the topic of the talk is
Cancer.
what cancer of what organ? Sure. So lung cancer, of course, can give you unilateral lymphangitic carcinomatosis. What is the other neoplasm that's notorious for unilateral or asymmetric lymphangitic carcinomatosis? What would that be? No, not carcinoid. Breast cancer, yes. Those are the two lesions the two tumors that can do this, okay? So what we see with lymphangitic carcinomatosis will have interlobular septal thickening that outlines the secondary pulmonary lobules, but there's also nodularity associated with that. So if there's nodularity associated with the interlobular septal thickening, then you especially need to consider lymphangitic carcinomatosis. So here we have the lymphatics are permeated with tumor cells. Okay, so the tumor cells are in the lymphatics. There's the lymphatics with tumor cells in there. And if we're thinking about this, you can recommend transbronchial biopsy because transbronchial biopsy has a very high positive yield for lymphangitic carcinomatosis. Okay? So the tumors that can do it, lung cancer, breast cancer, upper abdominal tumors also can give you lymphangitic carcinomatosis. Any tumor, though, can give you lymphangitic carcinomatosis. So we can see interstitial abnormalities on the chest radiograph with lymphangitic carcinomatosis, curly B lines. You might have pleural effusions, you might have lymphadenopathy on the chest radiograph. This was a patient with prostate cancer. You can see the metaport, kind of reticular nodular opacities here on the chest radiograph. And on the CT, there's interlobular septal thickening that outlines the secondary pulmonary lobules, but it's nodular, right? So nodular interlobular septal thickening, not very smooth, is the hallmark of lymphangitic carcinomatosis. Because the lymphatics run in the interlobar septae along just right around the secondary pulmonary lobules, what's marked in green here, and also along the airways. So you can also have parabronchial vascular thickening, interstitial thickening with lymphangitic carcinomatosis, because that's where the lymphatics run. So outlining of these secondary pulmonary lobules like that, especially with nodularity. There is no fibrosis, there is no architectural distortion with lymphangitic carcinomatosis, which helps you differentiate this from fibrotic diseases like sarcoid or idiopathic pulmonary fibrosis that might also be associated with some interlobular septal thickening. Here's another very typical appearance. Notice the secondary pulmonary lobules are very well outlined by the interlobular septal thickening, but it's not smooth. It's kind of lumpy, kind of thick, and somewhat nodular, okay, those interlobular septae. So when you see that, you think of lymphangitic carcinomatosis. Pulmonary edema, on the other hand, is the most common disease mistaken for lymphangitic carcinomatosis. This gives you very smooth interlobular septal thickening. Notice how smooth that is, how thin the septa are, even though they are thickened, and there is no nodularity here with the interlobular septal thickening. So pulmonary edema is, of course, the most common cause of interlobular septal thickening that you will run into. So pulmonary edema, sarcoid can also give you nodular interlobular septal thickening. Sarcoid, though, tends to be associated with fibrosis, and we can have architectural distortion. Same thing is true of silicosis and co-workers pneumoconiosis. And with pulmonary fibrosis, the septal thickening tends not to be as extensive as we see with lymphangitic carcinomatosis. And here, of course, you will also have traction bronchiectasis and other signs of fibrosis and architectural distortion. Now, since we're on the topic of lung cancer, there are complications of immunotherapy, so this is also something that you need to think about. The bottom line is, if you see unexpected opacities on CT in a patient with lung cancer, with a history of lung cancer, check the treatment history, okay? So we can have pneumonitis associated with immunotherapy for lung cancer, usually in the first 12 weeks of treatments. Patients can get organizing pneumonia. They can get these peripheral opacities. They can have a nonspecific interstitial pneumonia where they have peripheral ground glass opacities. So if we have funny looking opacities in a patient with lung cancer, check the treatment history because we may be dealing with a reaction to immunotherapy. There are other strange reactions that can also occur. There are various types of autoimmune responses like sarcoid. The sarcoid-like reaction can also occur with immunotherapy. So these patients can have nodules along, we talked about interlobular septal nodules. They can get that with these sarcoid-like reactions. They can have lymphadenopathy. And you can imagine this would be it would be very difficult to differentiate this from the actual neoplasm. But these are other things that you might also consider, especially if these occur rather suddenly in a patient who is on immunotherapy. So if you see unexpected opacities on CT in a lung cancer patient, check the treatment history because these reactions to immunotherapy might be something else you might think about in your differential diagnosis. So not all opacities in these patients with lung cancer are actually lung cancer. All right, so this is a patient 9 months prior, had a tumor, we can see on the old study, comes into the ER, we do a CT, and we find something that looks like this, okay? So any explanation for what this strange looking opacities might represent in this patient?
Radiation fibrosis.
So what suggests that it might be radiation?
Pretty linear.
That straight line, yeah, that straight margin here. And then here we might be, this is around where the tumor was. So here there's maybe some post-radiation fibrosis. But this straight line here suggests that we might be dealing with a patient who has received radiation therapy. So this is something else to consider in patients with a history of lung cancer. And you can also, if the radiation therapy is done here, we can get access to the radiation therapy ports, the portals that are actually used. And they can match up nicely. You can match it up nicely with the abnormalities that we see on the CT so that we can say that the changes that we see on the CT scan then represent post-radiation changes in this particular patient. Here's a very classic appearance, very straight margin here, not respecting anatomic boundaries, and you can see bronchiectasis and fibrosis in these areas where we have the post-radiation change. So that's a very typical finding of radiation change in these patients. So there's a latent phase immediately after therapy. There's a phase of acute radiation pneumonitis where patients develop ground glass opacities and consolidations, and then that transforms into the fibrotic phase 6 to 12 months later, and then the fibrotic phase usually stabilizes once you're out about a year after conventional, this is conventional radiation therapy. So there will be acute changes where you can have ground glass opacities and consolidations. You have to be careful here if the patient has a PET scan because these post-radiation changes will be very active on your PET scan. So it's going to be hard to differentiate that from neoplasm very early on. And then that goes on to a fibrotic phase later on once you get out to about a year later and you get architectural distortion and bronchiectasis representing the fibrosis, the post-radiation fibrosis. So acute radiation pneumonitis is when we have consolidations like that are in the radiation field, so they can be very sharply marginated depending on how the field itself, how the field itself was placed. So before radiation therapy, there was a tumor here. After therapy, you can see what the radiation portal looked like here. You can see the consolidation conforms to the radiation portal in that particular patient. And then as time goes on, then we start to get contraction and fibrosis, and we start to get loss of volume there as we get into the fibrotic phase. So that tends to stabilize at about 12 to 18 months after radiation therapy. So here's another example where we have the post-radiation pneumonitis, and then that transforms to fibrosis as the opacities get smaller, but we get more architectural distortion in the area of the radiation field. So pre-treatment, there's the tumor. 3 months after, you can see the post-radiation pneumonitis, where the radiation port was placed. And then 6 months later, it starts to get smaller. A year later, now it's fibrosed down and contracts. And at about this point, it tends to stabilize in terms of the appearance. And we've talked about this classic appearance of a conventional radiation therapy port and what that looks like on CT. So here's a nice evolution over time, radiation pneumonitis here. 5 months later, you can see it starts to get a little bit smaller. 13 months later, it's getting smaller. Now we see some fibrosis occurring there and traction bronchiectasis. And then it tends to stabilize here, not much difference between 13 months and 20 months. Now this is all for conventional radiation therapy. So here's a 56-year-old woman who presents to the emergency room here, and we have this funny looking opacity here. We pull out the x-ray from a year ago, and it turns out there was a mass there. And then on the CT scan, this is what this looks like, okay? So all of this turns out to be post-radiation fibrosis. And you have to think about this as you're looking at the images, as you're interpreting it, to try to see if we can get that history from from the patient or from the records. So whenever we have a patient who has lung cancer, has a history of lung cancer, and we see funny looking opacities, think about immunotherapy, think about radiation therapy. Now, so far what we've discussed is for conventional radiation therapy. Nowadays we have high precision dose radiation therapy, all right, and the terms that are used for this: 3D conformal, intensity modulated, stereotactic, sometimes even proton therapy. And so what is done here is these are strategies to maximize the dose, the radiation dose to the actual tumor, and to minimize the dose to the surrounding more normal lung tissue. Okay, so they can rotate the radiation ports, and the idea is to maximize the dose to the tumor and to minimize the dose to the surrounding more normal lung. So you have these color-coded patterns here where it can show you where the maximum dose is and how the dose drops away as you get to the more normal lung surrounding the tumor. And so what happens here is when we're following these patients with CT, whereas with conventional radiation therapy, the radiation changes occur right around the tumor. With these types of high precision radiation therapy, because they're rotating the radiation ports, we can have post-radiation change in other parts of the lung that are much further away from the tumor. So the tumor, can be here, and we can have post-radiation change over here in the other lung, pretty far away from the tumor. So you have to realize this also as you're interpreting the CT scans, your follow-up CT scans on these patients who are receiving treatment, okay? So if in doubt, try to check the radiation field to see if that part of the lung was included in the radiation field for these patients. So here's 4 months after therapy, 4 years after therapy. It turns out that with high precision radiation therapy, the changes can continue to evolve for up to 4 years later. So up to 4 years later, we can still see changes in the lung in these patients, okay? And then the different types of fibrosis we can see in these patients. We can have a modified conventional pattern where it looks very similar to our traditional radiation therapy fibrosis. We can have a scar-like pattern where you just get this linear opacity that turns out to be a scar. And then we can have a mass-like pattern where it looks like a mass. And this can be difficult to differentiate from recurrent tumor when you see that mass-like pattern of radiation fibrosis. So there are certain high-risk features that we look for when we're following these patients who have had radiation therapy. If there's an enlarging opacity at the tumor site, of course, then you have to think that, okay, maybe this is recurrent tumor. If there's a growth over several CT scans, if there are bulging margins. So all of these would make you suspicious, any of these findings on a CT scan in a patient who's received radiation would make you suspicious that there is recurrence after radiation. And then there you can't suggest PET-CT or biopsy PET-CT, especially if you're far enough out away from when the therapy was done, can be helpful to differentiate radiation fibrosis from the recurrent tumor itself, okay? You have to be careful because very early on after radiation therapy, the lungs will be very active on PET. So very early on, it's not going to help you, but later on, when all of that active inflammation is cooled off, then you can use PET to differentiate recurrent tumor from post-radiation fibrosis. Okay? So another kind of interesting phenomenon you can get is what's called radiation recall pneumonitis. So it turns out that radiation therapy itself, the theory behind this is that induces formations of cytokines. And then after the radiation therapy has been completed, if the patient receives chemotherapy or immunotherapy, that triggers an increase in those cytokines where the patient has had the radiation therapy. So that the patient then, when they started on immunotherapy, even though it's much later than their radiation therapy, actually develops pneumonitis, active pneumonitis in the radiation therapy field. So they can develop this active pneumonitis in the radiation therapy field after initiating treatment with immunotherapy or chemotherapy, and that is called radiation recall pneumonitis. Right, so this is something else to think about in your differential diagnosis for strange-looking opacities in a patient with a history of lung cancer. Radiation-induced neoplasm, so this is cancer actually induced by the radiation therapy itself. So this is not recurrence of the original tumor. This occurs many years after the therapy. So recurrent tumor will occur within a few years after therapy, but this occurs about 10 years after radiation therapy. And so here, what we look for is actually a new opacity within the radiation. So here was the original tumor treated with radiation, and then the patient develops this new opacity here in the radiation field many, many years after their initial therapy, and it's positive on PET scan. So this is a radiation-induced neoplasm. This is not recurrence of the original tumor. So this occurs many years after their radiation therapy. This is a 62-year-old man with shortness of breath who comes in with this very strange-looking chest radiograph. Here is the CT on this patient. Here's another image from the CT scan. How do we put the story together to make sense of what's going on in this patient? How do we put the findings on these images together to figure out what's going on in this patient? Well, what?
I was going to say, possibly hepatocellular cancer, treatment.
Yeah, because what are the findings here? Here you have a cirrhotic-looking liver. There's a mass here in the left lobe of the liver. So hepatocellular cancer, what is the treatment for hepatocellular carcinoma that can give you opacities like that in the lung parenchyma? Y90 therapy, right. So the Y90 therapy, if there's a significant shunt from the liver to the lungs, some of that agent gets into the lungs and causes radiation damage to the lungs. So this can be a complication also of Y90 treatment for hepatocellular carcinoma. So Y90 pneumonitis occurs 4 to 6 weeks after Y90 embolization. So these drugs are radiosensitizers that can of course make the patient more susceptible, associated with lung dose greater than 30 gray. And it tends to give you these bat wing type of perihilar consolidations. And so this is why before the patient is given therapy, they will calculate a lung shunt fraction, and that's calculated by an intraarterial injection of technetium-99 MAA, and they will calculate a lung shunt fraction. So the patient will go to nuclear medicine imaging, and from the images, from the data, they will calculate how much shunting is going to the lung. If that's greater than 20%, it's a contraindication to the procedure. So a lung shunt fraction here you can see of 52% looks like this. On your nuclear medicine study, 12.5% looks like this. Greater than 20% is a contraindication. Okay. So this patient had a lung shunt fraction of 23%, got the therapy anyway, and developed Y90 pneumonitis as a result of this therapy. Right? Another 70-year-old woman who received therapy for this tumor. Immediately after their scan, you can see there's a little bit of activity here within the lungs, comes back sometime later and develops these consolidations in the lungs from Y90 pneumonitis. So something else to consider, if we have funny looking opacities in a patient who is a cirrhotic, check to see about that history. Has the patient received Y90 therapy? Okay, because this you can also include then in your differential diagnosis. All right, so that is our discussion of neoplasms